Hi guys, if you can hear me, I'm just going to leave another couple minutes to let people join if they're running a couple minutes late. If anyone could you drop a message to say that you can hear me okay? Oh, great. Thanks for that. Great. Okay, so we've got a few more people joining, so I might as well get started. Thank you for joining, everyone. My name's Max. I'm one of the doctors working at Sunderland Royal and working with Mind the Bleep and another doctor, Dr. Allah, to design this cardiology teaching series for the UKMLA. This session specifically is going to be on bradyarrhythmias. So we'll go into what they are, uh, how they might present, the different ECG examples about how they might present, and how we treat them. So if we get started. What we'll be trying to get out of the session today is kind of defining a bradyarrhythmia and what it is, how it, as you said, how it might present, and to be able to use the ALS algorithm and how it comes in for critical bradyarrhythmias, but also at the same time to know that it's kind of not a God save. But we'll go into that when we cover specifically the ALS slide, and appreciate when someone might need pacemaker insertion and the kind of caveats to that and such. So what actually is a bradyarrhythmia? So essentially it defines down to a heart rhythm disturbance that results in a heart rate less than 60 beats per minute. Uh, there's no specific one bradyarrhythmia that causes this. A whole multitude of electrical conduction disease can cause a bradyarrhythmia. So it's really important to appreciate the different types and the different ECG examples of what can cause a bradyarrhythmia, which we'll be going into. So this is a really useful slide on the electrical conduction system of the heart. And we can see from the following examples that we're going to go through that the majority of bradyarrhythmias arise from electrical conduction diseases of the heart, if not iatrogenic causes like medications and such. But in structural causes, damage to the conduction system is what causes bradyarrhythmias. So just to quickly go through the electrical conduction system of the heart, it obviously starts off with the sinoatrial node, which then transmits down to the AV node, the bundle of His, which then divides into the bundle branches, left and right. Often it's not covered very well during med school, but the left bundle branch actually splits into the left anterior and left posterior fascicles before dividing into the Purkinje fibers and causing ventricular myocyte contraction. So how can these arrhythmias present? So let's say you're working in the emergency department or in the acute assessment suite or under cardiology. You might see various people coming in with different bradyarrhythmias. However, they can all present pretty similarly, and it's important to have some key structural concepts around how these arrhythmias can present. I find it useful to think about the presentation of these bradyarrhythmias by dividing their symptoms into three kind of core structural concepts. So there's going to be the symptoms that arise secondary to cerebral hypoperfusion, the symptoms that arise secondary to having actual bradycardia and how that can affect the heart. And there's also going to be the symptoms that arise secondary to kind of low cardiac output, which you could think that cerebral hypoperfusion is secondary to low cardiac output. But the majority of the symptoms that arise that you might take a history from, the majority of these symptoms classically are secondary to the cerebral hyperperfusion. So if we tackle the cerebral hyperperfusion, so it's a low low blood volume getting to the brain, which is secondary to the bradycardia. So the bradycardia is meaning that we're not getting an adequate blood supply to the brain, and that can lead to symptoms like syncope. So we know that when the brain isn't getting enough oxygen, then it shuts down as a protective mechanism. So that can lead to syncope. It can lead, if it's not bad enough to cause true syncope, but is still leading to reduced cerebral perfusion, then it can lead to kind of pre-syncopal symptoms like dizziness, lightheadedness. If the arrhythmia is intermittent and serious enough to cause syncope, it can cause a presentation known as Stokes-Adam attacks. So that's classically seen in intermittent complete heart block. So what happens here is the heart is intermittently going into complete heart block, which we'll go into later down the line. And these people classically present with syncopal episodes lasting between 20 and 30 seconds in length. That's associated with kind of pallor and bradycardia at the time of these syncopal episodes, rapid syncope and rapid recovery as well, and kind of flushing as the heart recovers afterwards. But then they can go back into syncope, so it's recurrent attacks. So these are known as Stokes-Adam attacks. In regards to the bradycardia itself, then we can think about how the bradycardia is going to affect the heart as a muscle. So if the bradycardia is severe enough, or bradyarrhythmia rather, if the bradyarrhythmia is severe enough to be causing myocardial ischemia, because we know that the heart supplies itself with blood, then it can cause chest pain. And it can potentially lead to symptoms like acute heart failure and dyspnea. And if it's very severe enough, although this is rare, it can lead to cardiogenic shock as well. So we've talked about cerebral hyperperfusion, how that can present, so syncope, pre-syncope, and potentially Stokes-Adams attacks. If the bradyarrhythmia is well, and we've talked about how it can affect the heart, so dyspnea, chest pain, potentially heart failure if it's severe enough. But then we also just have to think about how it's going to, and then it kind of comes back together in reduced cardiac output, can present with, well, and it's how it can present in terms of how the patient feels as well. So it can cause palpitations, fluttering of the heart rate. If it's causing severe enough palpitations that the patient can feel it, then it can present with palpitations as well, although that's less common. Typically, the classic symptoms you see in bradyarrhythmias is syncopal episodes with sudden onset and a lack of warning, with rapid recovery. And if it's severe enough, it can cause symptoms of heart failure as well. I hope that makes sense. And let me know if you can't hear me at any point. So let's get stuck into it about the different bradyarrhythmias that we can see commonly in practice. So this is probably the most common ECG example. Sinus bradycardia is completely normal in young, healthy individuals and can be as a result of increased vagal tone. However, it can be pathological if there is a sinus node disease that's causing reduced automaticity and therefore reduced contraction. So sinus bradycardia can be completely normal in a young, healthy individual. However, as we age, it can be secondary to sinus node disease. Also, another important factor that could be causing it as well, it could be iatrogenic, for example, and beta blockers or digoxin can cause significant bradycardia as well. I don't know if anyone wants to put in the chat. I'll stay silent for a couple of seconds. We can see the sinus bradycardia in this image, but can anyone see a particular addition to this ECG that you wouldn't normally see on a typical sinus reading? Not to give you any hints, but I think it's particularly well viewed, it potentially leads to or V2. You can clearly see it as well. So I haven't had anything in the chat, so I don't want to waste people's time by staying silent too long. Essentially, what I was looking for is U waves. So you can see that after the T waves on, particularly in V2 and lead 2, you can see a minor upwards deflection after the T wave. Now, these U waves in bradycardia can be completely normal and often get larger as the bradycardia worsens. So this is a completely normal ECG. Well, apart from the bradycardia, but there's no kind of pathological reason that there's U waves in here. And typically the U waves disappear as the heart rate gets quicker and can get slightly larger as the heart rate slows down as well. So this is the ECG showing quite a significant sinus pause. Now, there's no defined terminology, but it's kind of accepted that a sinus pause longer than 3 seconds can be known as sinus arrest, hence why I've called it that, because this pause is clearly longer than 3 seconds. Now, this is the failure for the sinoatrial node to fire, leading to kind of an asystole-like picture. Now, there's a couple of things to look at with the ECG. So one question might be, why are they going so quickly afterwards, followed by the periods of pauses? So this is what is colloquially known as tachybrady syndrome. So what's happening in this case is there is some form of tachyarrhythmia. For example, this looks like it could be AF, or fast AF rather, that is being generated from an impulse outside of the sinoatrial node to somewhere within the atria that's overriding the sinoatrial node. So the sinoatrial node is not having to fire because there's an impulse, a faster impulse coming from somewhere else in the atria. We know it's normally coming from somewhere within the pulmonary veins if it is AF. So we've got this impulse that's overriding the sinoatrial node and going quickly. So then when this AF, or this tachyarrhythmia rather, terminates, then the sinoatrial node has to wake up and start firing again. Now, in diseased sinus nodes, so for example, as we age, tachybrady syndrome gets more common, especially if there's kind of concurrent structural heart disease as well. Then as we age, it gets more common. So sinus node disease gets more common as we age as well. So in this case, their sinus node isn't waking up and going back into sinus rhythm as it should, and they're intermittently going in between atrial fibrillation or tachyarrhythmia and these prolonged sinus pauses, also known as sinus arrest, as the SA node fails to wake up. Now, if we can imagine that the tachyarrhythmia didn't start up again, then we would hope that the sinus, or the sinus node, or the SA node or the sinoatrial node rather, would start to wake up and go back into sinus rhythm. But they keep going into this tachyarrhythmia, so we're not getting the chance to see that. Furthermore, if a tachyarrhythmia or normal sinoatrial node firing did not take place, and this person was potentially leading into asystole, we would hope to see some form of escape rhythm, potentially a junctional or ventricular escape rhythm take place, which we'll go into later in the session. So the next arrhythmia that we can see is sinus arrhythmia. So this is very common. Often young, healthy athletes can have this, and it's associated with increased vagal tone. So as we age, our vagal tone gets less, so our incidence of sinus arrhythmia decreases as we age as well. So I won't go into the pure physiology of why sinus arrhythmia occurs, but essentially it's due to respiration patterns. So as we take a deep breath in, our heart rate can slow down. And then as we breathe out, our heart rate speeds back up, and especially, and this is secondary to increased vagal tone, which is more likely as we are in young, healthy individuals. Now, it's a bit of a, it can't, so if you see the ECG in an elderly person who's come in potentially with symptoms, it's less likely, well, it's not going to be sinus arrhythmia as such, because we know that sinus arrhythmia occurs as a result of respiratory or respiration and increased vagal tone. If we see this ECG in someone with a diseased sinoatrial node, this is more likely to be secondary to kind of sinoatrial node misfiring or missing a beat rather than actual sinus arrhythmia itself. So just to summarize what we've talked about there. So sinus arrhythmia is an intermittent QRS variability. So we can see there it speeds up and slows down at point. That comes in hand with respiration patterns as a result of increased vagal tone in young, healthy individuals. Now, if it can be pathological in elderly population, it could look like this, although if this was in an elderly person, then it wouldn't be known as sinus arrhythmia. This would just be kind of sinus node dysfunction. So the next ECG that I'll show you is ventricular standstill. So we can see in this ECG to the left of the image, there is a singular beat followed by lots of P waves and no QRSs. So this is quite a concerning rhythm, especially if you see it on a rhythm strip, because this indicates that at this stage there is no myocardial output, so there's no cardiac output, there's no ventricular contractions taking place. And the more concerning thing about this is that there's no escape rhythms. So we would expect someone with ventricular standstill to have some form of junctional or ventricular escape rhythm that would then manifest in the ECG looking like complete heart block. However, that's not the case here. So this indicates that this person, whoever's ECG this is, does not have a form of escape rhythm, and therefore you can treat this like in terms of a cardiac output point of view as asystole. So this, if it doesn't pick up again, would lead to kind of a kind of standstill of cardiac output, syncopal cardiac arrest, and often this is intermittent. So you would see this on telemetry, for example, for someone overnight went into ventricular standstill for a period of seconds and therefore they didn't actually die. But if this was prolonged, then it would lead to kind of asystole. If you see this rhythm on telemetry or another form of cardiac monitoring like an ECG, then it would certainly be an indication to get a cardiologist involved, and they would very, very, very likely need a pacemaker. So next, kind of moving down into the AV nodal blocks, of which we know there are a few. Feel free to drop any questions in the chat. By the way, I've got the chat open and I'll happily pause if anyone's got any questions. So the first block we're going to come across is first degree heart block. Now, this is essentially boils down to just delay in AV nodal conduction. So we can see on the ECG here that there is a prolonged distance between the P wave and the QRS complexes. So we know that the P wave corresponds to atrial contraction and the QRS complexes correspond to ventricular contraction. And now we know that a prolonged distance between the two means that there just must be a prolonged time between atria and ventricular contraction. Now in first degree heart block, this happens as a result of delayed AV node conduction. Okay, now this is normally due to vagal tone and can be completely normal in young, healthy individuals and often does not produce symptoms. So seeing this ECG in a elderly person who's potentially come in with syncopal symptoms, there is less of an indication to go for pacing rather than the further degrees of heart block. Certainly in someone presenting with first-degree heart block who's come in with syncopal-like symptoms, the other causes of potential syncope should be investigated and potentially prioritized rather than just going straight for a pacemaker insertion. A common example of that is first-degree heart block can very commonly be seen in elderly populations, and we know they often present with vasovagal episodes. Certainly not every elderly person who's presented with a vasovagal sounding like episode with first-degree heart block will be getting a pacemaker. That's just not how it's going to work. So this is generally considered quite a safe rhythm to be in. So secondary heart block, now divided into Mobitz type 1 or Mobitz type 2. So Mobitz type 1 is on the left, Mobitz type 2 is on the right. So Mobitz type 1, also known as Wenckebach's phenomenon, is characterized by a slightly prolonging PR interval at each beat until a beat is a QRS complex is dropped, and then the PR segment kind of revamps itself, and then they get slightly prolonged, and the kind of picture repeats itself, normally at a categorized kind of 3 to 4 beat intervals, as we can see on this ECG strip to our left here now as well. So with the eye of faith, I know it's not particularly obvious. We can see the PR interval is slightly prolonging at each after each QRS complexes before QRS complex is missed completely. Now, Mobitz type 1 occurs as a result of AV node fatigue. Okay, so we know that there's a refractory period within the AV node, and just as a result of potentially vagal or iatrogenic causes, it causes increased AV node fatigue. So every now and again, or every third or fourth beat, a QRS complex is dropped. Now this, as it's because of AV node fatigue and not actual structural damage to the AV node itself or infranodal structural tissue like the bundle of His or the bundle of branches, is generally considered quite a safe rhythm as well, and there's less of an indication to pace people or insert a pacemaker with Mobitz type 1 AV block. Moving on to the second secondary heart block, that's Mobitz type 2. This is characterized by a fixed PR interval. So we can see here on the rhythm strip that the PR segment actually looks completely normal. It's often misunderstood that you need an extended PR interval for the heart blocks. That's just not true. The PR segment in this Mobitz type 2 block can be considered completely normal. However, the key factor in second degree heart block Mobitz 2 is that you get intermittently missed or dropped QRS complexes. Now this as it is different to Mobitz 1, which we just talked about, occurs as a result of AV node fatigue. This is as a result of structural heart disease. So you get Mobitz type 2 heart block as a result of structural heart disease. So intermittently, the conduction system is failing to transmit to the ventricles. Now, this is concerning. The primary reason that this is concerning is because at any point, this can lead to transfer or conversion into complete heart block, which we know is a very dangerous rhythm. We'll go into that in a second. So Mobitz type 2 heart block is an indication for pacing, often if the patients are asymptomatic, but certainly if they're symptomatic as well. So if they've come in with pre-syncopal or syncopal-like symptoms or symptoms of any kind of decreased cardiac output with Mobitz type 2 heart block, that patient will be getting a pacemaker due to the risk of conversion to complete heart block, which we know can deteriorate into asystole. So moving on to the final AV nodal block, so it's third degree heart block. So this is characterized by a complete dissociation between the P waves and the QRS complexes. So we can see in this rhythm strip that there is a fixed P to P interval, so the P waves are coming at regular intervals, and there's a fixed R to R interval, so the QRS complexes are coming at regular intervals as well, but there's no association between the P waves and the QRS complexes. Now, this can be difficult to appreciate at points because often the T waves can bury the P waves. Often, a good example of that could be complex number 1, 2, 3, 4. Oops. The T wave that follows QRS complex number 4, you can see that little notch is probably, well, it's going to be a kind of covered P wave that the T wave is just kind of engulfing. So that's why it can be difficult to appreciate at points. However, if you were to trace this, you would see that the P would be fixed and the R to R interval would be fixed, but there's no correlation between the two. There is complete AV nodal kind of dissociation. The AV node is not transmitting to the firing, and there is an escape rhythm distal to the AV node that is firing as well. But the heart is certainly not conducting a normal kind of conduction system. Now, you can see different forms of AV block, or complete heart block rather, and by that I mean you can see a slightly slower QRS complex rate between the rates of 20 to 40 with broad complex QRSs. This indicates that the escape rhythm is coming from the ventricles. However, you can also see, and this is a good example in the ECG above, that you can see narrow complex QRSs with a rate of between 40 and 60. Now, this indicates that the escape rhythm is coming just distal to the AV node at the junction. So this is known as a junctional escape rhythm. So this would be a complete heart block with a junctional escape rhythm. Now, because, I mean, if we just think of physiology, a heart rate of 60 is going to be more likely to sustain life than a heart rate of 25. A narrow complex QRS with a complete heart block is generally considered more favorable, or we can wait on it longer before pacemaker insertion than a broad complex complete heart block, as for the reasons I've just described. So we can just move on to the bundle branch blocks. So we can see here we've got a left and a right bundle branch block. So the key way to recognize the bundle branch blocks, I particularly like to use the RSR pattern in V1. And by the RSR pattern, I mean upwards flip-like tick. And this can be seen in the bottom ECG example. So the bottom ECG example is a right bundle branch block. So if we just focus on V1, you've got the classic RSR pattern, also known as a bunny ears pattern. So you can see there's an upwards tick of the QRS complex followed by a downwards, so that's the RS, followed by another upwards flick. So I don't know if you can see me hovering. This is where I'm focusing on. So that's the RSR pattern in V1. It's also classically associated with deep S waves in V6 as well. So that's your classic presentation of a right bundle branch block. Now, all that means, or what does a right bundle branch block mean? It means that the right bundle that we saw on the initial image of the electrical conduction system of the heart is blocked and therefore isn't transmitting impulses properly. Therefore, the left bundle, or can split into left anterior and left posterior fascicular bundles, will have to contract the right side of the heart using kind of myocyte to myocyte contraction. This is generally slower than using the conduction system, hence the broad QRS complexes, because it takes longer for the heart or the ventricles to contract, because it's having to go from myocyte to myocyte from the left to the right side of the heart because one of the bundles is blocked, hence the broad QRSs. It's also a reason why if you see a potential left bundle branch block or right bundle branch block, so broad QRS in someone who's suffering with chronic heart failure, that you might consider cardiac resynchronization therapy, because we can appreciate that the ventricles contracting together at the same time would be more beneficial than one ventricle contracting after the other, as is seen in kind of bundle branch blocks. However, that's kind of digressing. The classic symptom ECG pattern we see in the left bundle branch block is a cousin of in the right bundle branch block. So you can see similar broad QRS complexes, and you can see the RSR pattern in V6. Now it's difficult to kind of hone in on V6 and zoom in, but you can see the kind of notch at the top is indicating a kind of downwards deflection, although it's kind of being engulfed by the next R wave. So it's only a tiny little notch there. But you can see instead of the RSR pattern in V1, the RSR pattern's happening in V6. So this is classic of a left bundle branch block. So moving on to bifascicular block. So this just correlates to how many of the heart's fascicles are blocked. So we know from the image of the heart's conduction system that we had at the start of the session that we've got two bundle branch, well, three if you count the division of the left bundle. So you've got the right bundle and the left bundle that splits into the left anterior and the left posterior fascicle. So if we've got a right bundle branch block with one of the fascicles left fascicles being blocked, either the left anterior or the left posterior, then that's known as a bifascicular block. That means we've only got one fascicle left. So it's indicating a greater, it means there's more structural heart disease that's probably happened that's caused damage to the bundles. So this is more classically seen in patients who have had previous structural heart damage, potentially previous MIs or heart failure, for example. So we can see in this ECG, they've got the RSR pattern in V1 and deep S waves in V6. So they've got a right bundle branch block with a broad QRS. Now, we won't be able to kind of work it out on this ECG alone, but the severe left axis deviation that we can see in 1 and 3, you'd have to formally work out the axis, but that is indicating that there is left anterior fascicular block. So you can see severe left axis deviation noted by the upwards QRS complexes in 1 and the downwards QRS complexes in lead 3. That indicates left axis deviation, and that can indicate left anterior fascicular block. So we can see here that there is a right bundle with a left anterior fascicular block, indicating bifascicular block. Now, if this patient was asymptomatic, it wouldn't indicate a pacemaker insertion. However, if they've come in with symptoms suggestive of some form of bradyarrhythmia and low cardiac output state, potentially a syncopal episode that doesn't sound particularly vasovagal and would raise concerns of a potential bradyarrhythmia, then this would be an indication for pacemaker insertion because they've only got one functioning fascicle left. Now, trifascicular block is quite an interesting one because often people think or call trifascicular block, if I go back to the bifascicular block, with if this person had first-degree AV block with bifascicular block, then often people incorrectly call this trifascicular block. The reason it's incorrect is because there is no progression of, or no increased progression to complete heart block with bifascicular block without first-degree AV block compared to bifascicular block with first-degree AV block. About that, first-degree AV block is just a delay in AV nodal conduction, but all the complexes are coming through. It's typically vaguely mediated. It doesn't indicate there's structural damage to the heart. So a bifascicular block with a first-degree AV block should just be treated as bifascicular block. There's no increased danger or no increased incidence of progression to complete heart block with bifascicular block with it first-degree AV block. So we shouldn't call that trifascicular block. True trifascicular block, as we can see in this image, is complete heart block. So we can see a fixed P to P interval and a fixed R to R interval with right bundle branch block and left anterior or left posterior fascicular block. So that indicates that there is only one functioning fascicle, and that fascicle is probably producing an escape rhythm that's causing ventricular contraction because there's complete heart block happening as well. So the AV node is damaged, or distal to the AV node is damaged, so it's not transmitting impulses to the ventricles. So there's an escape rhythm happening, and there's also evidence of structural heart disease elsewhere in the heart because there's a right bundle branch block and a left anterior or posterior. I mean, in this case, it's a left anterior fascicular block because we can see there's extreme left axis deviation. I hope that makes sense. It's quite a complicated topic. To summarize that, this patient would be getting a pacemaker, irrespective of whether there was kind of right bundle branch block or left anterior fascicular block, because there's evidence of complete heart block here. In practice, this person would be getting a pacemaker. So I've talked about escape rhythms a lot. So just to kind of go over what escape rhythms are. So we know that at each point in the electrical conduction system within the heart, it is capable of generating its own electrical impulses if the conduction system fails to act and override them. So the only reason you don't get a ventricular escape rhythm in normal sinus rhythm is because the sinoatrial node is functioning well, therefore leading to the AV node functioning well. It's overriding the ventricular escape rhythms that would be there if it wasn't, and therefore it's kind of being suppressed. However, when there's severe structural heart disease, we get these escape rhythms because the heart's conduction system isn't working well. It's quite a remarkable feat of kind of physiology, really, that the heart's capable of producing its own conduction systems when the actual true conduction system fails to work. So we can see here that the ventricles are contracting with broad complexes at a rate of about 30 beats per minute. So this would be considered a ventricular escape rhythm. Again, this is another image that would be this is another ECG example, sorry, of complete heart block. So it's probably best appreciated in well, we can use the rhythm strip because it gives us a good example of the kind of classic or a longer ECG example. Particularly at the end of these, you can see there's a fixed P to B interval. The previous P wave there is probably and a fixed R to R interval there as well. So we can see that this person's in complete heart block with a ventricular escape rhythm, which we can appreciate that it's a ventricular escape rhythm from the broad complexes and the slower rate than you would see in a junctional escape rhythm. So this is a junctional escape rhythm. This is a good example. Again, complete heart block. We can see the P waves. There's a fixed P to P interval. There's a fixed R to R interval, but there's no correlation between the two. However, we can appreciate that the QRS complexes here are narrow and going at about a rate of 60 beats per minute. So this is classic of a junctional escape rhythm. Okay, so this is another good indication of why narrow complex complete heart blocks with junctional escape rhythms are considered more favorable in terms of being able to kind of sit on them without immediate pacemaker insertion compared to this. This is a much nastier ECG example compared to this. We can appreciate how this person would probably look a bit better, you know, if we were doing another bedogram kind of person presented, we can appreciate how this person would probably look a bit healthier than this person right now. So moving on to the ALS algorithm. So we can briefly run through it. However, the reason I've kind of included this on, because we all know, or we can all recognize or remember an algorithm, and it's not a particularly difficult algorithm to memorize. However, what I want to kind of drill in here is that there may be situations where you wouldn't expect the algorithm to work because of the physiology of the drugs that they're recommending here. So it's important to have a higher level appreciation of when, you know, a person is definitely going to need pacing rather than just interim measures with drugs like atropine and isoprenaline and adrenaline, for example. So just going through the algorithm, if you've got someone with symptomatic bradycardia, you're going to do an A2E, you're going to correct the A2E as it comes up, give them oxygen if they need it, get an ECG, see what rhythm they're in. If there's evidence of kind of life-threatening shock in the same way that in the tachyarrhythmia algorithm, we look for signs of heart failure, so shock, syncope, myocardial ischemia, or heart failure. The algorithm recommends giving IV atropine, and then you potentially give it again, if they're still showing signs of life-threatening ischemia or shock, or you can give other medications like isoprenaline or adrenaline. And essentially all of these are trying to do is trying to kind of bump up the heart rate to give them a better cardiac output. And then you're going to try and contact cardiology because the person's going to probably need pacing. On the other side of the algorithm, if they're not showing any signs of shock, then the algorithm then goes into, well, is there a significant risk of progressing into kind of asystole in this person who's presented? And if there is, then it kind of moves on to the side of the algorithm where it suggests giving these medications. So the risk of asystole, risk factors, they've given a kind of recent asystole, whether they're in Mobitz 2 AV block, which we've talked about, and why that's dangerous, because there's a risk of development of complete heart block and therefore progression to asystole. Whether there's complete heart block with a broad QRS, we've talked about why broad QRSs are more dangerous than narrow QRSs, because typically narrow QRSs are junctional and therefore have a faster heart rate, or if there's significant ventricular pauses greater than 3 seconds. So that's the kind of sinus arrest or the ventricular standstill that we've talked about. So then it kind of recommends drugs, so atropine, isoprenaline, or adrenaline. Now, the issue I want to highlight here is it just comes down to basic physiology, really. Atropine, the main medication that's recommended in the ALS algorithm for bradycardia, acts on the SA node to increase the rate that it's firing. It's kind of vaguely mediated. So that's why it's going to be really helpful if you've got something like symptomatic bradycardia, because it's going to act directly on the vagal system to increase the rate that the SA node is firing, and therefore indirectly act on the AV and the rest of the conduction system via the SA node. However, we've kind of touched on how the damaged conduction system of the heart, potentially secondary to structural heart disease, if there's damage to the AV node itself, and they're in potentially complete heart block due to damage to the AV node or distal to the AV node, then it's very unlikely to respond to measures like atropine, because all the atropine is going to do is increase the rate at which the atria are firing. It won't affect the damaged conduction system to that distally. So essentially what I'm trying to kind of put a point to is that the patients in complete heart block and are symptomatic of this are going to need some form of either temporary via transcutaneous or transvenous pacing or permanent pacemaker insertion. So we want to get cardiology involved at the soonest possible availability. Another point on which I haven't got a slide on, but it's important to know, is if a person goes into complete heart block post myocardial infarction. So there's potentially two reasons why someone might go into complete heart block post MI. If they've had a inferior MI, we know that the inferior aspect of the heart is supplied by the right coronary artery, and the right coronary artery also supplies directly to the AV node. So if the AV node becomes ischemic secondary to an inferior MI affecting the right coronary artery, then you can get kind of ischemia, inflammation, and that can transiently reduce the ability for the AV node to conduct impulses. So you can get transient AV block post inferior MI. Now, this is not usually an indication to pace someone. They should be kind of managed with interim measures whilst the AV node recovers And then obviously if it doesn't get better, then you would have to pace them or put in a pacemaker. But it's usually transient in an inferior infarct. The other side of the coin is if they've had a massive left anterior descending or a massive anterior infarct that has kind of blown hell to the leather of the whole conduction system. They might be in complete heart block secondary to that. They might just not have a functioning conduction system anymore. So they might have a ventricular escape rhythm originating from somewhere in the ventricles that's not part of the conduction system because the whole conduction system's shot, basically. This would be an indication to put in a pacemaker because that's not going to recover. If you've damaged the whole conduction system as a result of an infarct or an ischemic insult, in a LAD insult, then they're going to need a pacemaker if they've gone into complete heart block. They've probably also got a pretty poor prognosis if you've kind of damaged the whole conduction system in that infarct, because it indicates it's probably quite a big infarct as well. What are the indications for pacemaker insertion? We've kind of gone through them as we've kind of gone along the examples of the bradyarrhythmias, but the clear indications for a pacemaker insertion are third degree or Mobitz 2 heart block. This is because in third degree heart block, there's a risk of progression to asystole, and there often also isn't a cardiac output to sustain life, especially if there's a ventricular escape rhythm, and they're going at a ventricular rate of 25 or 30 beats per minute. That's not going to be sustainable. So there's the risk of progression to asystole, and it's also quite a dangerous rhythm in itself for cardiac output. So they're going to need a pacemaker. And then Mobitz 2 heart block, we know has the risk of progression to complete heart block and therefore asystole as well. So they're going to require a pacemaker insertion. Generally, if these patients are asymptomatic, they'll get a pacemaker. If they're symptomatic, they're definitely going to get a pacemaker. Other indications for pacemaker is symptomatic, so clear symptoms with sinus node dysfunction. Again, it varies trust by trust and cardiologist by cardiologist. So having a pacemaker isn't a massive procedure or a massive operation. So I've seen cardiologists put in pacemakers for a ventricular sinus arrest of 6 to 7 seconds, basically, which probably is an indication for a pacemaker. But even if the patient was asymptomatic, they still suggested a pacemaker. But definitely symptomatic sinus node dysfunction. So symptomatic bradycardia that obviously isn't attributable to drugs or anything reversible. Symptomatic bradycardia would be an indication to have a pacemaker, especially if the patient's coming in with syncope and severe symptoms, potentially heart failure. Symptomatic chronotropic incompetence. What does this mean? Essentially, if a person is exercising and their heart rate doesn't increase acceptably whilst the exercise, we all know that our heart rate increases in line with the intensity of exercise that we're doing. Often with a damaged sinus node, it doesn't. So the heart rate just stays at 60 or 70 beats per minute, even though they're trying to run a 5K. That's not going to work. So that person's going to need a pacemaker. And syncope secondary to hypersensitive carotid sinus syndrome. Potentially, as we age, we can get a potential hypersensitive carotid sinus, and that basically means that with light pressure to the carotid sinus, which is kind of located around our neck, potentially, putting on a shirt or something like that, or bending their neck, then they could get a massive kind of vagal spike and then go severely bradycardic and symptomatic from that. It's usually transient, but if this patient's, it's quite rare, but that would be an indication for a pacemaker as well. So thank you for sticking with me for so long. We're kind of 50 minutes in so far. It's quite a short topic, so I only intended this session to be kind of an hour's long. We've gone through a lot of arrhythmias and bradyarrhythmias. So well done if you stuck with me this long as well. So I just went through some questions. It's not the most covered topic in medical exams, but it's a very important topic. I don't know why it's not covered as much because we see it very commonly in clinical practice, pacemaker insertions and the reasons for it. However, there actually weren't that many questions on PassMed for bradyarrhythmias. However, here's one, and I've kind of got some of them. So we've got a 78-year-old in ED who's had a fall, feeling dizzy and lightheaded before losing consciousness. She's pale, clammy, she's slightly hypotensive, and she's bradycardic. An ECG shows sinus bradycardia with no evidence of AV block or bundle branch block. The patient has a history of hypertension for which she takes amlodipine once a day. She has no drug allergies. So how do we manage this patient immediately in the emergency department? You can either put it in the chat or just have it in your head. I'll probably give it 30 seconds before I reveal the answer. So I struggle with silences, so I'm going to move on. hopefully, hopefully we've all had a chance to read the question and have a think about what management would be doing for this symptomatically bradycardic patient. So the answer is atropine. Why is that? So we've got a symptomatic bradycardic patient who's on an antihypertensive, who's had a kind of sounds like a syncopal episode at home. How are we going to manage them immediately? So we know that we've talked to that sinus bradycardia is generally as a result of either iatrogenic or reduced vagal or now atropine acts on the vagal system to increase the rate at which the sinoatrial node fires. So this would definitely be an arrhythmia that would respond to atropine. So atropine is a very good medication that we can give first line. Furthermore, there sounds like there's a potential reversible cause here about why she's bradycardic because she's on amlodipine. So it's not a typical agent that causes bradycardia, but maybe she's taken an accidental overdose or something like that. So as it said in this explanation, it may be related to amlodipine. So we'd be giving atropine in the first instance, seeing if her heart rate responds and managing her symptoms as they come up. So atropine would definitely be the first line in this case. And we talked, I didn't mention it, but you can give up to 3 milligrams of adrenaline in the initial response, and that's in the algorithm as well. So next question. A 56-year-old gent is brought in by paramedics. He's fainted and has not regained consciousness. There's no injuries from the faint. His heart rate is 37 beats per minute. His respirate is 16. His blood pressure is fine. You order an ECG, and the ECG shows a prolonged PR interval. What would be the initial management? So hopefully you've all had a chance to read the question. So it'd be atropine again. And we talked about how when we were going over, so it sounds like this person has first degree heart block with a symptomatic bradycardia alongside it. But we've talked about how first degree heart block is just a delay in the AV node transmission. That's not going to be causing a slow sinoatrial node in this case. So it's probably unrelated to the bradycardia that he's got, and it would likely respond to atropine. So similar to the last question, but it's important to know which bradycardias, which we call bradyarrhythmias, are normally at the like vaguely mediated, so like sinus bradycardia, first degree heart block, and those that are associated with structural heart disease that probably aren't going to respond to atropine, like Mobitz 2 heart block or complete heart block. I don't think this is the correct answer. I'm just highlighting it here. I think I just accidentally clicked on it, and you can't unclick on PassMed. So ignore that. So you've got a 62-year-old man is referred to the emergency department with a pulse of 40 beats per minute. Which of the following factors carries the least risk of asystole when risk stratifying the patient? So you've got ventricular pause, recent asystole, complete heart block with a narrow complex QRS, Mobitz type 2 AV block, complete heart block with a broad complex QRS. So going to the answer. So it's a narrow complex QRS. So this is because what we've talked about, that if there's a narrow complex QRS with complete heart block, that indicates that there's a junctional escape rhythm taking place. And these are normally narrow complex with a rate of between 40 and 60 beats per minute. And that can be hemodynamically kind of acceptable, as it says in the STEM, for patients. So final question, I think. A 72-year-old man is admitted to the emergency department with chest pain. He's known to be pale, a heart rate of 40 beats per minute, and blood pressure of 90/60. What one of the coronary arteries is most likely to be affected? Give a few more seconds to have a think about that. So moving on to the answer. So it's the right coronary artery. So we know that the right coronary artery supplies the AV node. So ischemia or insult to the right coronary artery can lead to AV node damage, and therefore kind of inflammation, infarction, and therefore it can transiently block the AV node, so it can lead to complete heart block. I suppose what we've talked about is, could this be a left anterior MI causing massive damage to the conduction system and therefore complete heart block? Yes, but the person would probably be in cardiac arrest if they've had sustained such a serious import, and probably wouldn't be conscious if their whole conduction system is being wiped out by this MI. So if you see complete heart block during an MI, it's more likely to be right coronary. So these are just some references. I got most of the ECGs from Life in the Fast Lane, which is a fantastic resource if anyone is interested in different arrhythmias or just interested in ED/cardiology. It's a fantastic website. Questions I got from PassMed. The pacemaker indications it's on NICE guidelines, but there's a good review article that I've linked, and the cardiac cycle image I got from Nottingham University website. Thank you very much for joining. We've run this session with Mind the Bleep, so there are some good discount codes linked here. I think there's normally a QR or a feedback link at the bottom of the YouTube link, or however you've joined, to leave feedback via Mind the Bleep. But both myself and Ala are running a quality improvement project about how we can improve our sessions and medical education generally. So if you'd be happy to fill that in, we'd really appreciate it. And it would just kind of give an indication of what we can do better during these sessions and how we can improve for the future. So thank you very much. I'll stay on if anyone's got any questions for a couple of minutes. If anyone wants to scan the QR code, that'd be brilliant. And thank you very much.